Hello, my name is Saul Wiener, and this is the 8th in a series of videos on contextualizing care. In this one, I'm going to talk about how to enrich clinical teaching cases with patient life context. Now, the cases you're probably accustomed to seeing are, at least to me, what I might describe as archetypes. They sort of remind me of mannequins in that they have a basic structure, and on that structure we hang a set of diagnoses and treatment options with a basic narrative, like this is a 73-year-old man or a 43-year-old woman with diabetes, hypertension, and so forth. Now, this framework does have its merits in terms of simplification, but one of the limitations is that it's not how medicine is actually practiced. And when you don't consider a patient life context in the educational setting, you may be less likely to do it in the clinical setting, and as a result, become the kind of physician who misses clues that your patient is struggling with some life issue that's complicating their care, and as a result, miss opportunities to help them. Those of you who have seen the third video know that these contextual errors, as we call them, adversely affect patient care. I think that considering patient life context is something that we should be teaching and reinforcing across the medical education curriculum, starting at the very beginning of medical school. Imagine, for instance, how things would be different if every clinical teaching case had embedded life context. So, for instance, in a basic pharmacology class where you're being asked, what's the best drug for this bug? A follow-up question would be, okay, so what are you going to do if the patient can't afford it? And if we took this approach, then by the time medical students were ready to start their clerkships, they would be habituated to thinking about patient life context. This video is designed to stand alone, but I encourage you to have a look at some of the earlier ones, particularly the first 4. Those of you who have know that there's a strong evidence base for contextualizing care. We've analyzed over 6,000 audio recordings of physician-patient encounters, and we've seen that when physicians take patient life context into account, their patients have a range of better outcomes, confirming that patient life context is essential information to providing effective care. And that's why we should embed patient life context in our clinical teaching cases. So let's get started. I want to start by acknowledging that embedding patient life context in clinical teaching cases is a bit of a culture change. At first, it may even seem like a distraction from the meat of a case. In fact, it's actually often the stuff we remove from real life cases when we're distilling them for teaching purposes. For instance, if in real life your particular patient wasn't taking their medications correctly because they couldn't afford to do so, or if there wasn't a place to inject themselves at work, or their vision is too poor to read the bottle, whatever the personal challenge may be, that's the stuff you might omit when you present at grand rounds or on a podcast or at a meeting. And yet confronting these challenges is part of being a physician. Now, this slide is taken from the very first video. In brief, patient context refers to everything that is expressed outside of a patient's skin that's relevant to planning their care. That's the precise definition we use when applying for research grants. A more relatable way of saying more or less the same thing is that patient context refers to patient or caregiver circumstances and behaviors that are relevant to planning patient care. So, for instance, a patient with diabetes who's not able to take their insulin because they can't afford it. That would be patient context. Or not caring for themselves well because they're depressed. Or losing control of their diabetes because of vision problems, since they can't read their insulin syringe accurately. Or having to rely on family, who prepare meals that are not well suited to their nutritional needs. Or being totally overwhelmed by work and children to the point where they're forgetting to take their medication because of so many other priorities. As you can see, the possibilities are practically endless. So now that you know what we mean by patient context, I'd like to introduce the term contextualized care. We say that a care plan is contextualized when it considers patient life context. And this slide is taken from video number 2, which has more details. In brief, contextualizing care is a 4-step process. First, it begins with the clinician recognizing contextual red flags, and these are clues that something in a patient's life situation might be impacting their care. Then, second, the clinician, upon noticing a contextual red flag or flags, asks about them to find out what might be impacting the patient's ability to manage their care. Third, the patient discloses any underlying contextual factors, and that's the patient context. And finally, the clinician contextualizes the care plan by taking contextual factors into account so that the care plan will be effective. And here's an example taken from an audio-recorded visit. Ms. G presented with a loss of control of her diabetes and hypertension. Glycated hemoglobin was 9.7, and it had previously been 7.0. That's the contextual red flag. The physician expressed concern and then probed by asking Ms. G if she knew what was going on. In response, she said she'd moved recently and that her medications got, quote, all messed up. She mentioned that her daughter was concerned too, and that's the contextual factor. And finally, in response, the physician suggested that the pharmacy package her meds in blister packs. This plan turned out to be especially helpful because Ms. G had been having trouble opening her medicine bottles because of arthritis in her hands. So that's the contextualized care plan. And at a follow-up visit 4 months later, her diabetes and blood pressure were back under control. Now, here's an example of what happens when the clinician overlooks the patient context. When that happens, instead of saying the care was contextualized, we say there's been a contextual error. The case, which is the same as the last one, starts out with Ms. G presenting with a loss of control of her 2 chronic conditions. Again, the physician probes, and again, she reveals the contextual factor. But this time, the physician, while sympathetic, is not helpful. While they acknowledge that moving is challenging and disruptive, there's no plan. And perhaps not surprisingly, at 4 months, the diabetes and blood pressure are still not well controlled. Over the years, we've come to appreciate that contextual factors can be conveniently sorted into 12 broad categories, what we call domains of patient context. The ones on the left are life circumstances, things that literally occur outside the skin. For instance, not having transportation would be in the domain of access to care. Competing responsibilities could include taking care of a sick and totally dependent family member. Now, it could also be something positive, like getting a job or working the night shift. It's important to note that context is not always something bad. Getting a job is generally good, but even so, it may mean having to alter a treatment plan if, for instance, a patient can no longer take their medicine at a specific time or make it to certain appointments, and so forth. When those things happen, the care plan has to be adjusted. And now, the 6 contextual domains on the right are all drivers of behavior. For instance, take emotional state. If a patient is depressed, they may stop taking their medications as directed. And if they have diabetes, you may first get wind that they're having a problem because their A1C is going up. So the point is that you won't be able to manage the diabetes until you address the context, which is, in this case, their depression. Now, if we think about Ms. G, the question is which of these domains applies best? Remember, she's having trouble keeping track of her medications and also opening bottles because of her arthritis. So I'd say that these contextual factors fall in the domain of skills, abilities, and knowledge. So now that we've gone over some background, let's turn to the task of adding patient context to a clinical teaching case. I've picked this one from a recent Curbsiders podcast. It happens to be the 329th episode, but really, any case will do. Here we have a patient named Theo, who is a 58-year-old man with obesity, hypertension, hyperlipidemia on lisinopril and atorvastatin. The physical exam is unremarkable. The labs show that the patient is infected with hepatitis C. The source of this infection is not immediately clear. We're introduced to the workup, which is pretty complex. I learned a lot, and the treatment plan. During the case discussion that follows, we hear that the patient chose one of the 2 treatment options. He actually chose Sofel and was subsequently cured. Now, let's say we want to add patient context to enrich the case. The first step is to go and have a look at the 12 domains and think about which ones we want to draw on. So, for instance, take financial situation. We know that cost is a huge barrier for many patients seeking care for hepatitis C. And for that reason, we may want to enrich our case with an issue related to cost. We could do that by having the patient on Medicare and having him say that he still can't afford treatment, which is currently a real issue. So we'd make that the contextual red flag. A question for the learner would be, okay, what would you want to know and what would you ask him? A suggested contextual probe could be, I see you're covered by Medicare. The share of costs you pay for hepatitis C treatment is still high. Is that the problem you've been having? The patient would then say, yes, that is the problem. He'd add that he's been told he'd have to pay $600 per month, which in fact is currently true for a lot of Medicare plans. Now, with that information, the learner could be asked to consider what they do next. A proposed approach here for contextualized care plan would be to consult a social worker who could then determine if the patient is eligible for extra help, which is a Medicare subsidy for low-income beneficiaries that would likely cover much, if not all, of the gap. So this is just an example. The point is that you're enriching the case with some sort of relevant contextual factor. Now, how you choose to present this information depends on the learning situation. For instance, if this is for a podcast, you won't be able to interact with your learners. You can actually ask them questions like, what would your contextual probe be? Or if you were to ask that question, it would be rhetorical. You'd have to tell them what you'd suggest an effective probe might actually look like. On the other hand, if the case is going to be used in the classroom or at a resident conference, for instance, I think it's really useful to ask your learners what questions they'd pose to the patient to probe the contextual red flag. I found that even experienced physicians sometimes struggle with how best to formulate contextual probes. Okay, another relevant domain you could draw on, in addition to or instead of access, is the environment in which a patient lives. For instance, there's a lot of evidence that living with other people who inject drugs can trigger a relapse. So you could construct a narrative in which Theo has a history of IV drug abuse and is now in recovery. He's living with his sister where it's easy to stay abstinent, but is thinking of moving back in with some old friends, one of whom he used to share needles with. His sister is aware and concerned. And then, based on the narrative, you can enrich the case with the following red flag, probe, contextual factor, and contextualized care plan. As you can see, it begins with Theo commenting that, my sister thinks I should keep staying with her. Again, this is a good opportunity for the learner to think about how they'd respond to a comment like that. The suggested probe here is, quote, why do you think your sister seems concerned about your moving out? The patient then discloses that one of the guys he's planning to move in with is someone who he used to inject drugs with, while adding that he's certain his friend is clean now, although that should not be all that reassuring. It does provide, however, a good opportunity to talk about what might be a contextualized response. The suggested one here is to explain to Theo that you share his sister's concern that moving in with his friend could be a trigger for a relapse. And finally, here's one more we might use, since depression is disproportionately common in patients with hepatitis C and could put our patient at risk for medication non-adherence and for relapse. In this version, the contextual red flag would be two poorly controlled chronic conditions suggesting poor medication adherence. The learners might be asked to reflect on what questions they'd ask. A suggested contextual probe could be, quote, I notice you've been having a hard time controlling your diabetes and hypertension. Is something getting in the way of your taking your medications? The contextual factor, then, would be the patient revealing that he's been distracted and down lately, not feeling right. He's not sleeping well and has lost his appetite, too. And of course, the contextualized care plan would be to treat the depression. Putting it all together, you now have a case that's enriched with patient context. So in addition to learning about how to diagnose, evaluate, and treat hepatitis C, the learner gets to think about costs of care, comorbid depression, and triggers for relapse, all of which are contextual factors. Now, of course, you don't have to put all of them in the case. That's up to you. When you're drafting a case, these factors should be embedded in real-life organic ways, starting with contextual flags, like the casual mention that the sister didn't want the patient to move out. And finally, when there is an opportunity to interact, learners can be challenged to consider what questions they'd ask and what they do with the information. And remember, everything is built around the contextual factor, so you always have to decide first what your contextual factor is going to be, whether it's a cost issue, depression, or a bad roommate, or something else. Once you have that, you can come up with 3 other elements you'll need for a fully fleshed out contextualized case. I'm referring here to the red flag, the probe, and the contextualized care plan. So that's how it's done. Before we close, I'd like to share with you a Venn diagram that gives a 30,000-foot view of what we're doing here. Basically, it shows that making good clinical decisions requires integrating 4 different types of information. The first is the clinical state, which we see at the top. That refers to all the patient's active medical conditions, including what diagnoses they have, like diabetes or COPD, and the status of those conditions, such as whether they're well controlled or poorly controlled. That information comes from the medical history, physical exam, labs, imaging, and diagnostic tests. The second kind of information we need is the relevant research evidence for managing that clinical state. Traditional teaching cases tend to focus on these two. They're designed to show how to apply the best research evidence to a particular clinical state, and often they stop there. However, there are two other potential sources of information that should always be considered. One is the patient context, which is what we've been talking about, and the other is patient preferences. So for instance, in the hepatitis C case, Mr. Theo was given the option of choosing between two different regimens. That was an example of eliciting patient preferences. Real life and good clinical decision-making requires integrating all four of these types of information. In our research, however, we found that all too often clinical decisions mirror teaching cases. Clinicians elicit the clinical state and then, hopefully, apply the research evidence. That's good, but often not enough. So consider creating cases that remind your learners to elicit context and preferences and show them by the way you construct your cases that it matters to getting the care plan right. As always, thank you for your interest.